Hello, everybody. It really is my pleasure to speak to you today at the OSSM Third Primary Care Update. And I will be speaking to you today about osteoporosis, a practical approach. These are my disclosures, and I have received research funding for the development of new molecules for the treatment of osteoporosis and parathyroid disease. Our learning objectives today are: how do we evaluate fracture risk? What are the benefits of therapy? And what are the risks of therapy? I wanted to begin by reminding everybody that osteoporosis is a condition which has decreased bone strength, and this is associated with an increased risk of fracture. And bone strength is determined by two important parameters. One is the quantity of bone, which is measured by bone density assessment, and the second is the quality of bone. And we do not evaluate the quality of bone by the bone density assessment. And it is important for us to remember that bone strength is an integration of both of these factors. So for this reason, we cannot base the diagnosis of osteoporosis purely on the results of a bone density assessment. And we need to integrate other factors in evaluating the diagnosis and the risk of fracture. And so the diagnosis of osteoporosis is made by two ways. It can be made clinically in the presence of a fragility fracture, which is a fracture which happens with a fall from standing height. Or if you're running down the stairs and you fall from the third step or lower, if there's a fracture, then that would be a fragility fracture. The fracture sites that are not included in this definition are face, hands, feet, and ankles. And we can make the densitometric diagnosis of osteoporosis if the T-score, comparing our bone density to the young adult normal reference range, is minus 2.5 or less at the lumbar spine, hip, femoral neck, total hip sites, and the 1/3 radial site. So there's two ways to make the diagnosis of osteoporosis, and we don't require a T-score definition of minus 2.5 or less to make a diagnosis of osteoporosis. We have two tools available to us in Canada to evaluate fracture risk. To assess the fracture risk, we need to integrate other risk factors for fracture. That includes age, it includes prior fracture, parental history of a hip fracture, smoking status, steroid use, rheumatoid arthritis, secondary causes of osteoporosis, alcohol excess, and we can also add the bone density. And when we integrate all of these risk factors together, we're able to evaluate fracture risk by the FRAX tool, which will then give us two pieces of information. One is, what is the risk of a major osteoporotic fracture over the next 10 years? And major osteoporotic fracture sites are hip, spine, forearm, and humerus. And also gives us the risk of a hip fracture over the next 10 years. And if the major osteoporotic fracture risk is more than 20%, and if the risk of hip fracture is more than 3%, we have to treat these people. We can also assess fracture risk with the CAROC tool in Canada. And it's a very simple tool based on gender, and it's based on age of the patient and prior fracture risk and steroid use. And basically, it will give us a number which would indicate whether the patient is at a low, moderate, or high fracture risk. And the two tools are complementary. So whether you use a FRAX tool or whether you use CAROC, it doesn't really matter as long as you're using a tool. That's the important thing. Now, can we evaluate fracture risk without a bone density? Well, there was a very important study done, and the Norwegian population was evaluated looking at close to 30,000 men and women between the ages of 50 and 90. And FRAX without BMD was calculated, and the hip fracture incidence was observed prospectively with a median follow-up of 5.2 years. And observed fractures were compared to what was predicted by FRAX at baseline. And what was seen was the area under the curve for women was 0.81. That means that this model of FRAX without BMD has an 81% chance of predicting who will have a hip fracture. and that's pretty good. The area under the curve for men was 0.79. So we can use FRAX without BMD. So if we don't have access to BMD, depending on where we are, or if the patient in a pandemic is not able to travel to an X-ray department to have a bone density assessment done, it's not a problem. We can calculate the fracture risk using FRAX without BMD. Now, it's important to remember that falls in the past year are an additional risk factor independent of the FRAX score for fracture risk estimation. And we also need to include the risk of falls. And falls is not currently included in FRAX, which is one of the limitations of FRAX. So we always ask about fall history. And if a patient has had a fall in the past year, if they've had 1 or 2 falls in the past year, we need to integrate that information into the fracture risk assessment. There is a Canadian meta-analysis that was completed recently showing us that FRAX with BMD has a higher discriminative ability for osteoporotic fracture than FRAX without BMD. So if we do have the information, the BMD data, then obviously we're going to be able to more accurately define who will have a fracture. But if we don't have that information, it's not a problem. We can still use FRAX without BMD. So currently we recommend that if someone has had a fragility fracture, this confirms the presence of osteoporosis. And if someone has had a hip or a vertebral fracture or more than one fracture, this confirms a high fracture risk. If someone has had a prior fragility fracture and they've been on steroids, 7.5 milligrams for 3 months or longer, they would also have a high fracture risk. So we need to evaluate our patient. We're not just treating bone density numbers. We're treating patients, and we need to integrate the clinical information with the BMD information, make the right diagnosis, and then evaluate fracture risk and decide who to treat. Now, we have to exclude secondary causes of bone loss because if we look at the postmenopausal female population, approximately 1/3 of those patients will have another secondary cause for bone loss beyond estrogen deficiency. And if we do not carefully evaluate them, we're going to miss that secondary cause. And if we look at the male population, approximately 45% of those individuals have a secondary cause for their osteoporosis. It's important for us to take a careful history, review their medications, and review the prior fracture history and the history of falls. And if we're doing an OTN assessment, virtual assessment, look at how well the patient can stand without use of the arm rest. Look to see if they have kyphosis. And if there is concern that they've lost 2 centimeters of height or more, then it's important to do spinal x-rays and document the presence of a vertebral fracture. And we email or mail a lab requisition to the patient and ensure that we do the lab tests to exclude the differential diagnosis of osteoporosis. Because it's not only hypogonadism that causes osteoporosis. Body weight and gonadal status are the 2 key determinants of bone density and bone strength, but there are many other hormonal abnormalities that can cause osteoporosis. There are drugs that can cause osteoporosis, and there are other factors like neuromuscular conditions, rheumatoid arthritis, renal tubular acidosis, malabsorptive states, any condition that prevents us from absorbing calcium and phosphate and magnesium and vitamin D can impair bone quality and bone strength. And we have to do a careful lab evaluation to exclude these factors. In men, evaluate gonadal function, and in women who are not yet into menopause, again, we have to evaluate gonadal function, and we evaluate all of these lab tests and exclude secondary causes of osteoporosis. This is key before we move to the next step, which is to treat a patient. We cannot treat a patient unless we know what their diagnosis is. In medicine, the first thing is do no harm. So how do we know that we're not harming them? If we don't know what the calcium corrected for albumin is, we don't know what the vitamin D is, if we start them on a potent anti-resorptive agent, we could cause them to become hypocalcemic and end up with a seizure and emerge. So it's critical to evaluate, and then start therapy. As I've mentioned, post-menopause, we see a rise in rank ligand signaling. Rank ligand is a signaling protein which is released by osteoblasts, and it binds to its receptor rank on pre-osteoclasts and causes these cells to fuse to become the osteoclast, which then releases acid and enzymes and causes bone resorption and causes the formation of a resorption pit. The osteoblast then moves in and fills in that resorption pit. In the hypogonadal male or female, these resorption pits are deeper. And there are other reasons why we have an increase in rank ligand expression. It's not just post-menopause or with hypogonadism in the male. It can also be with steroids. Steroids increase rank ligand expression. Hyperthyroidism increases rank ligand expression. Hyperparathyroidism increases rank ligand expression. Cancers increase rank ligand expression. Cytokines cause an increase in rank ligand expression. PTHRP increases rank ligand expression. So increased rank ligand expression is the final common pathway, the highway of increased bone resorption. So our ability to pharmacologically intervene in someone who has osteoporosis has traditionally been focused on inhibiting these excess osteoclasts. And we can use bisphosphonates and we can use denosumab. Two main pharmacologic modes of treatment. Bisphosphonates get buried into the skeleton. They're ingested by the osteoclast. They inhibit the mevalonic acid pathway downstream to the statins, and they cause the osteoclast to die. It prevents the osteoclast from forming its cytoskeleton, and it causes osteoclast apoptosis. What does denosumab do? It's a monoclonal antibody to rank ligand. So it actually prevents the formation and the function of excess osteoclasts. And both of these drugs will bring bone remodeling back into the premenopausal levels. It reduces the excess osteoclast activity, brings it back into balance with the osteoblast activity. So what about anabolic therapy? What does anabolic therapy do? Well, there are three anabolic molecules. Estrogen is actually an anabolic agent. And we didn't know that up until recently, just 2 or 3 years ago. We recognized that not only does estrogen decrease rank ligand expression, but also estrogen inhibits sclerostin. And sclerostin is a signaling protein which is released by osteocytes. And the osteocyte is the brain in the bone. And it releases sclerostin that blocks bone formation. It can also release Wnt, which activates bone formation. So this osteocyte is regulating bone resorption, it regulates bone formation, and it also regulates bone mineralization because it releases a bone hormone called FGF23 that regulates phosphate loss through the kidney. So estrogen is an anabolic agent. In a woman who is not yet 50, it is absolutely critical to offer estrogen as the first-line agent of choice if she is hypogonadal or if she has subclinical hypogonadism. It is critical to ensure that this individual is estrogen replete. And the same is true for men, but we don't have the same quality of data with androgen replacement therapy in hypogonadal men in comparison to the wealth of data that we have with bisphosphonates and with denosumab and with other molecules as well. So estrogen is essential for bone formation. We also have other molecules. We have romosozumab, which is a monoclonal antibody to sclerostin. And sclerostin, as I said, blocks bone formation. And so romosozumab will bind to the inhibitor of bone formation, and it allows this osteoblast to lay down more bone. Romosozumab will also decrease rank ligand expression because the two pathways are connected. And so romosozumab has a dual mechanism of action. It will stimulate new bone formation, and it decreases bone resorption. We have PTH and PTHRP. PTHRP is a abaloparatide. It's not yet available in Canada, but PTH is, and it's been around for 18 years. And PTH binds to PTH receptors on osteoblasts, and it will also inhibit sclerostin and cause these osteoblasts to lay down more bone. But PTH will increase rank ligand expression, and it will increase bone resorption as well. And so it's important for us to remember that these molecules have different mechanisms of action, and we need to use the right drug in the right patient for the right duration of therapy. Just a schematic illustration regarding the Wnt signaling pathway. This is an osteoblast. We can see on the surface we have the frizzled receptor. Wnt, which is released by osteoblasts and osteocytes, binds to its co-receptor LRP5. When this receptor is activated, it will result in activation of a protein called disheveled, which will inhibit glycogen synthase kinase. Glycogen synthase kinase, when it is inhibited, it will actually allow beta-catenin to accumulate because it will no longer be degraded. Beta-catenin enters the nucleus, and it will then bind to transcription factors, and it will result in gene transcription, and it will then allow this osteoblast to start pumping out collagen. And when we activate the Wnt signaling pathway, we will increase osteoprotegrin and decrease rank ligand. And also, because the pathways are connected, we will thereby decrease bone resorption. So who do we treat? We will treat people who have a high fracture risk. As I mentioned, whether you use FRAX or whether you use CAROC, if your patient's high fracture risk is 20% or more, we have to treat them. If they have a moderate fracture risk, and it's 10 to 20%, but they're not doing well, they're having bone loss or falls, or they have drugs associated with osteoporosis and progressive bone loss or impairment in bone quality, or they have diseases associated with osteoporosis, then we would treat these individuals as well. And if they have a very high fracture risk, and the fracture risk is most significantly elevated, where it could be as high as 1 in 4 over the next 2 years, and that would apply in someone who has had a fragility fracture, then we should consider using an anabolic agent up front. And that would be teriparatide or romosozumab, and use an anabolic agent, improve the structure of the skeleton, and then follow it with anti-resorptive therapy. Because we have data showing us that if we use the anabolic agent up front, we have a greater impact on bone density than if we were to switch the order and use an anti-resorptive agent up front. So if you use an anti-resorptive agent and then follow it with an anabolic agent, the impact on bone formation and bone density is attenuated. But if we use the anabolic agent up front, we have a better skeletal response. And this is what the Endocrine Society guidelines have recently recommended. And our Osteoporosis Canada guidelines are going to be coming out later this year. And we anticipate that it will also have the same emphasis on being aggressive in someone who has had a fragility fracture. Because if you've had a fragility fracture, the imminent risk of fracture, which is your risk of fracture over the next 2 years, is highest in the next 2 years. And it could be as high as 1 in 4. And this is showing us that regardless of the type of fracture the person has experienced, the risk of a second fracture within 2 years following that prior fracture is ranging between 15 to 25%. So, and obviously this is also age dependent. Older individuals have a higher risk of fracture for multiple reasons. And in this time period, we don't have time to delve into that, but it is critical to treat people aggressively after a fragility fracture. How do we treat them? So now we're at the treatment phase. Well, for the treatment of osteoporosis, once we know what type of osteoporosis they have, is it idiopathic postmenopausal osteoporosis? Is it steroid-induced osteoporosis? Is it osteoporosis in association with hyperparathyroidism? Or is it renal osteodystrophy? Now we know what we're dealing with. We know the fracture risk. We're going to start treatment. It is absolutely critical to ensure that vitamin D levels are normal. Vitamin D ensures that we have the optimal calcium phosphate product for bone mineralization. And not only is vitamin D important for skeletal response, it is also important in the immune system. And we recently put together a response from Osteoporosis Canada, emphasizing that in the COVID-19 pandemic, it is critical to ensure that everybody has a normal vitamin D. A normal vitamin D is 75 to 125 nanomoles per liter. Vitamin D may prevent the cytokine storm that is associated with ARDS and increased mortality, because vitamin D may prevent macrophages from releasing excessive inflammatory cytokines and chemokines. And it may also enhance the expression of angiotensin converting enzyme 2, which has been associated with improved outcomes with COVID-19 infections. So in particular, in those individuals who have a high risk of vitamin D insufficiency, the obese, the people who have malabsorption or short gut syndrome, or who are on long-term anticonvulsants, and our elderly patients, we need to ensure that their vitamin D levels are normal. What is the evidence then regarding the various treatment options that we have available? Teriparatide reduces vertebral and non-vertebral fractures, and we do have a meta-analysis confirming that it is effective in reducing hip fracture as well. Teriparatide is given for 2 years, 20 micrograms sub-Q daily. The bisphosphonates, the oral bisphosphonates and IV zoledronic acid, reduce the risk of vertebral, non-vertebral, and hip fracture risk. With the oral bisphosphonates, we have data out to 5 years. With IV zoledronic acid, we have data out to 3 years. With long-term data beyond those time periods, we do not have proven efficacy against non-vertebral fracture and hip fracture risk. So long-term bisphosphonates beyond 5 years with oral and beyond 3 years with IV zoledronic acid have not shown reductions in non-vertebral fracture or hip fracture risk. We do have impact on clinical vertebral fractures with the oral bisphosphonate alendronate and with morphometric vertebral fractures with the IV zoledronic acid. But beyond those time periods, 3 years for IV zoledronate and 5 years for oral bisphosphonates, we do not have long-term data with the oral bisphosphonates and IV zoledronic acid. What about denosumab? Denosumab reduces vertebral, non-vertebral, and hip fractures. And the RCT comparing the denosumab with placebo was for 3 years, and the extension trial was out to 10 years, and everybody in the extension trial was on denosumab, and the study showed ongoing reductions in vertebral fracture and non-vertebral fracture out to 10 years. Now, it's important to remember that the drugs are only effective as long as you're taking them. And this would apply for a drug that does not have long-term skeletal retention. With the bisphosphonates, we can stop the bisphosphonate, but when the bisphosphonate is stopped, because it has long-term skeletal retention, it will continue to have ongoing release from the skeleton, and it will continue to have some degree of anti-resorptive effect. So if our patient, after taking 5 years of bisphosphonates, has a moderate fracture risk, we could give them a drug holiday, and we can stop the bisphosphonate and simply follow them every 2 years. If there's a decrease in bone density or the experience of fracture, we would then give them another drug, possibly denosumab or teriparatide. So the only drug that we can stop and still expect to see some maintenance of bone density is the bisphosphonate. The other categories cannot be stopped because the other drugs do not have long-term skeletal retention. So denosumab is a monoclonal antibody. It will circulate in our bloodstream, and its effects are gone after 6 months. That's why we give a second dose. So if you stop denosumab and don't take a dose after the 6-month time period is up, then what will happen is there will be an increase in rank ligand expression, and there will be enhanced osteoclast activity, and the pre-osteoclasts that were not being converted to osteoclasts will all become osteoclasts. And after stopping denosumab, we see a rise in bone remodeling. So if a patient misses their dose of denosumab, within 4 to 6 weeks after, there is a rise in bone remodeling, and they could experience a fracture. And by 12 months after missing denosumab, the bone density will actually go down to baseline. And in the FREEDOM study, those people who stopped denosumab were evaluated, and what was seen was an increase in the risk of vertebral fracture. On therapy, the vertebral fracture rate was 1.2 per 100 patient years. Stopping therapy, the rate increased to 7.1 per 100 patient years in the group that was on denosumab. There was a rise also in the group that was on placebo. At baseline, there was 7.1 because they weren't on therapy, and there was a slight rise in that patient population as well. With age, patients will have more fractures. So when we stop denosumab therapy, there will be a rise in bone remodeling, and there will be an increase in the risk of fracture. And what we've seen in those patients who have stopped denosumab therapy is a rise in the risk of vertebral fractures. These are the people who are on placebo. This is the group that was on denosumab. And the proportion who had multiple vertebral fracture was actually higher in the group that had been on denosumab than the group that had been on placebo. And this was in the patient population that had previously had a vertebral fracture. So if your patient has very poor bone quality and they've already had a vertebral fracture, we cannot stop denosumab. In fact, we should not stop it without replacing it with something else in all patient populations. Because when we stop denosumab, when we stop estrogen, when we stop teriparatide, when we stop romosozumab, we have the loss of the benefit. It's like stopping antihypertensive therapy. The benefit is lost. The only drug that can be continued and still have ongoing effect is a bisphosphonate. But we do not give a drug holiday to any other molecule. Now, just in the interest of time, I just want to briefly remind us that there are differences in potency between anabolic therapy and anti-resorptive therapy. The Vero study was head-to-head study looking at teriparatide in comparison to risedronate. And in this study, that was a 24-month study, there was a dramatic reduction in new vertebral fractures in the teriparatide group in comparison to risedronate. So if we have a patient who has a high imminent fracture risk, am I going to treat this patient with risedronate, or am I going to give this patient teriparatide? Obviously, I'm going to give something more potent than risedronate. So in someone who has a high fracture risk, we prefer anabolic therapy, teriparatide or romosozumab. And because of the data that we have with denosumab in comparison to bisphosphonates with respect to the surrogate markers of fracture, which are bone density and biomarkers, if they can't go with teriparatide or romosozumab, I would prefer to give them denosumab than a bisphosphonate. So we have to move with the evidence. We don't just stay 20 years behind and give everybody bisphosphonates, because we know that anabolic therapy is better. And this is a study that was recently completed, and it showed us that romosozumab will have a far greater impact on bone structure than anti-resorptive therapy. In the FRAME study, everybody received romosozumab for the first 12 months in comparison to placebo, and then everybody was switched over. And I'll show you what happened over here. So in the FRAME study, romosozumab resulted in a dramatic rise in the bone density, and the improvement that was seen at the spine was what one would achieve with 5 years of denosumab. And the same was true at the total hip site. The improvement that was seen at the hip was comparable to close to 3.5 years of denosumab. So it allows us, anabolic therapy allows us to make a dramatic improvement in the structure of the skeleton and improve the quality and the quantity of bone. And the bottom line is reduce fractures as early as 6 months with romosozumab in comparison to placebo. And if we continue to look at these patients, you can see that the romosozumab group has an ongoing fracture risk reduction with respect to non-vertebral fractures and hip fractures. So the group that was on romosozumab in comparison to the group that was on alendronate had a significantly improved structure of the skeleton in the first 12 months. But this is the ART study, and it was continued out to 48 months. And so the group that was on romosozumab after 12 months was switched to alendronate. And the group that was on alendronate continued on alendronate. So here's head-to-head data, Romo versus alendronate. When you take the Romo for the first 12 months, it results in an improvement in fracture risk, which lasts you, even though you're no longer taking it. Now you've switched to alendronate, it still gives you fracture protection because of the improvements in the structure of the skeleton. There is an important major adverse cardiovascular event that we need to discuss. And when we looked at romosozumab in comparison to placebo, there was no increased risk of major adverse cardiovascular events. But romosozumab in comparison to alendronate, the alendronate group had 1.1% risk of major adverse cardiovascular events. The Romo group had 2% risk. And so for this differential risk in the risk of major adverse cardiovascular events, in the head-to-head study, there is a black box warning on the Romo label, and it says that we should not use this drug in someone who has had an MI or a stroke, and we need to respect that black box warning. So we've talked about drug holidays with bisphosphonates, and we've talked about the importance of not stopping the drugs that do not have long-term skeletal retention. What do we do if we want to stop denosumab? Well, we could consider giving them IV zoledronate, but a recent study has shown us that if you do IV zoledronate, there will still be progressive bone loss. We recently completed a study looking at low-dose denosumab, and we showed that low-dose denosumab is not associated with bone loss. So if you went from 60 milligrams of denosumab to 30 milligrams of denosumab, we do not see bone loss with this strategy. I'd like to conclude by saying that osteoporosis is unfortunately common. It's important for us to exclude secondary causes of osteoporosis. We need to be aggressive in our management of patients who have a high fracture risk, and we need to monitor our patients closely. And so with that, I'd like to thank you for your attention. I'd be happy to answer questions. Thank you.